Hi and welcome everyone. I can see that we are getting 80 participants. I think there's an enormous keenness to understand it, probably getting on to 100 people that are interested in listening to us today. So welcome. We'll just give it a few seconds more and then we'll proceed from there. So without much ado, apologies that we started a few minutes late. My name is Jhb Musa. I'm a family physician in Johannesburg, and we are basically, as the District Research Committee of Johannesburg, which I chair, we are trying to set up a webinar in which we can improve communication with researchers and to be able to improve the review process at least, and ensure that we can process it quickly. So we are very fortunate today to have people from the National Department of Health. Chalitsi Mutivi, welcome. He'll be there for a few comments, but we've got two people who present. Dr. Bridget Ikalafeng is the research coordinator of Gauteng Health, and she is the official that coordinates all processes that are within the Gauteng Department of Health, and will speak to us about the research process, how things work, what exactly is happening in Gauteng Health. Not everything is decided by units like the Johannesburg District Research Committee. So she'll talk to us about that in a few minutes. Then Ms. Tess Padayachee will come and speak about health, about using the NHRD, which I talked about previously. She'll give us a sense of it in a bit more depth, but she speaks on behalf of the Health System Trust. And as I mentioned, the actual custodians of the system are the National Department of Health. And we're fortunate in Chalitsi Mutivi from the National Department of Health being able to join us. Can you perhaps, is that, I wonder if that's Bridget that's asking the question. So I just want to quickly give me a few seconds, just check if Bridget is struggling, because as the first speaker, we'd like her to share a little bit. Let me just see if I can quickly call her. She's not answering her phone. She's on the call, but we're battling. Okay, well, all right, Bridget, and let me just see if I can get through to her, and we'll use the WhatsApp call and get her talking at least to us. Hi, Bridget. Are you able to speak through the WhatsApp? Is that going to work?
Yes, I'll speak through the WhatsApp.
All right. Okay, well, let's proceed. I will open up, let me stop sharing, and I will open up your presentation. Give me a few seconds, okay. And then you can, just tell me, I think you can see what's on the screen, and then you can just tell me next, and we can proceed from there. No problem. Give me 2 seconds. So I've got the presentation coming up shortly.
Okay, thank you.
Okay, so here's your presentation. Welcome and thank you to you, Bridget. Over to you, Bridget, and if you can, and as a microbiologist and a PhD working in the Gauteng Department of Health, it can't be very easy, but I think she can tell us what exactly happens. So thank you very much, Bridget, and share with us your challenges as well as how things are going and how we can improve the outcomes of applications. Thank you.
Okay, thanks a lot, Prof, for the invitation. Firstly, I think communications of such topic are really critical, especially pertaining to the research process in Gauteng. I'm the head of research and epidemiology in the province, as Professor already introduced me, with a wide background of environmental health and epidemiology. So my role here, I'm going to share with you where the process of research application has commenced. So I'm just going to give a bit of the act on what it stipulates. So I'm going to talk to that, and then the role of the PHRC, which are behind what type of research is carried out within the country, what is the research agenda. It should focus on the priority settings, and they should advise the minister on the application and implementation of an integrated national strategy, and also to coordinate all the research activities that are happening within the country. Now, the NHRC, obviously this is a very huge responsibility, so they found it best to develop a national health research policy, which can indicate on how to set up the provincial health research committees to help them implement their mandate. So in the next slide, that is how the Provincial Health Research Committee comes in the picture, and they broke down their functions, and the functions, the broad three functions are coordination of research, resource mobilization, and translation of research. So in terms of coordination, I will not probably go through all of them, but is to lead the priority settings, to coordinate the research, to mobilize the resources, and also to promote the use of health research outcomes, which is very critical. That is why the database is there to ensure that everything that we approve should be used in order to improve service delivery. So my next slide, the next goal focuses on number 6, which is to support the development and appropriate use of the NHRD. So the use of the NHRD and how it should be done, the research process, it's a key function of the PHRC. And what I'm now going to discuss with you, our current process and how we want to move forward in improving it, falls within this particular goal. And the others, of course, the last one, to use the best practices that are there in order to ensure that the research agenda is being established. Now, my next slide is just emphasizing on or stipulating on, in terms of resource mobilization, what the PHRC is expected to do, which is to lobby and give advice to the department on the internal use of research funding and promote trainings and research capacity development. And the last one, which is also very critical, is now the research translation. Now, without a waste of time, my next slide, I would like to, I've done this about the translation of research. The reports needs to be reviewed. That is why it is important that research should be kept on a central repository. The PHRC within the department, we are having a third term of the committee now. It started in 2012 and then 2015 and now 2018. We've been having this committee chaired by Professor Shirley Mutaung, who is the chair and founder of the Global Biotech and Assistant Dean of Research and Postgraduate and Innovation at the Tshwane University of Technology. And his deputy is Professor Yanni Hugo, who's the HOD for Family Medicine at UP. And these committee members are appointed by the MEC, and the process is through advertisements. And this list shows the other members, which includes Prof. Lekan. You served the DVC for Research, Postgraduate and Innovation at SMU, Prof. Maria Papathanasopoulos, Assistant Dean of Research and Innovation and Postgraduate Students at Wits, Professor Stein, Chair of Faculty of Health Sciences Ethics Committee, and Ms. Chani, the Program Manager at Oram, and Dr. Salamina Hlane at the Central Office, as well as Dr. Matson Sumatebula, Director of MECTRU at SMU. So these are the people that are responsible for the strategic agenda of the provincial research. And as one of the goals, I indicated that their role is to support the functioning of the NHRD, which Tess will talk, will talk deep, mostly on it. But I have 2 slides on that, which is just to tell us why the NHRD is there, to support the PHRC in terms of achieving those mandates, to create a repository for the research outputs, and to track the research trends and evaluate their alignment to the National Department of Health research priorities. So the objective of the NHRD is to standardize the process and systems of research and to reduce the duplication. That is why the researchers should upload on it, to ensure that other researchers can share the findings and be able to see that it's not a duplicate of the study that they want to do. So it's about sharing the knowledge and having the repository. Now let's get to the core of the presentation, which is how this process is currently working in Gauteng. So the research process in Gauteng is being coordinated by various research structures. After uploading on the NHRD, there are internal processes that are taking place, and all the districts have got research committees, and the hospitals have got research committees as well. If the ones that don't have research committees, they have responsible research persons for the reviews. Now, the PHRC grants permission for the clinical trials only. All the other research is being coordinated by the districts themselves and the hospitals. So district and hospital CEOs grant permission to the studies pertaining to their respective districts and hospitals. And Professor, you said I'm welcome to share my challenges. And the challenges really is that the processes are not the same for all the research structures and all the facilities. And that is what the PHRC is currently trying to streamline. And we hope to have finished the process before the end of the year, or in the next meeting, actually, to finalize our SOP. So the next slide just shows what is required. So the process is like that. On the NHRD, you log into the website as a researcher, you prepare your documents, your ethics, your full proposal, and if it's a clinical trial, your MCC approval, and then you fill in the application form on the NHRD. And then after that, it will give you an automated number that is your NHRD number. And after that, then there's an internal review process, which I'm going to go through in the next slide. And our turnaround time has been 6 weeks, but there has been really challenges of adhering to this turnaround time due to other issues that I will get into before the end of the slide. And the permission is supposed to be granted after that. And researchers are requested now to upload their monthly report every 6 months. So the next slide shows how the internal review works, which is after now the researchers have uploaded that protocol, the provincial NHRD administrator downloads it and sends it to the respective to the respective administrators, and these will be your district research committees, your hospital research committees, and the PHRC. Now, on the blocks there, I indicate that if research is to be done in one district, then that district approves the research and grants permission. If it's a clinical trial, the district still looks at it, sends comments, but then the PHRC gives final permission. If it's a hospital-based research, the hospital committee does the reviews and grants permission, and the CEO provides the final review, the final outcome. Now, this process has been quite long. We have admitted the turnaround time has been challenging to the researchers and been very frustrating. So there's a new proposed process that is currently under discussion, which is my next slide, which you can share with us there. And the new proposed process is that in the light that the turnaround time has been prolonged by all by sending the protocols from central office to the various research committees, and just to get the signed permission letter, which now needs to be uploaded for the researcher on the database. Wouldn't it be best that the researcher goes and gets the signed permission letter from themselves, from the HOD of the facility, and the facility provides the permission, and then the researcher comes and uploads all those requirements. So this is the process that is under discussion. This is the process that is currently under discussion to find out if this will expedite the whole process. And this can happen, if the researcher, depending on how fast or frequently goes to the hospital, can get that immediately for himself and then upload. However, the challenge that we are currently wanting to see in order for this to work well is how certain will we, what is the certainty of the researcher uploading the documents after receiving the hospital permission? And in the last meeting, this process has been consulted with all the stakeholders, and we are presented also to the management. But the stakeholders, some of them suggested that rather the institutions have their own numbers to ensure that the research will be uploaded on the document. So my next slide shows. Okay, this is the feedback of the consultations which I've discussed, that the certainty of uploading on the NHRD, because if they don't, then it will nullify the NHRD. And then, so it was suggested that central hospitals and tertiary hospitals be granted the NHRD funds, so that they should grant the permissions directly and immediately. And this process has been already commenced at the Biko academic hospitals and Kalafong. So the district, they are having their own funds already, but still relies on central office. And so these are two different processes, and the SOP might need to have two different pages or flowchart for the central hospitals and for the hospitals and the district. And the other thing that is a challenge now is that the ethics requires facility provisional permission before granting approval. So, and yet ethics, NHRD wants the ethics. But here we've also said to the facilities that ethics does not want a full permission letter. You're welcome to provide a provisional approval so that the researchers should get the ethics, and after the ethics, then upload on the NHRD. So these are the discussions that we are at the moment. So in the next slide, together with what was presented, what was proposed by the PHRC, the that new process that I presented. So the combined ideas was that the researchers should prepare all the documents and upload on the NHRD, and then the institution should download that application immediately and review it and grant them the permission letter immediately. And then after 6 months, they should send the completed process. Now, this consultation, it still needs to be finalized. Your webinar process came 2 weeks earlier than for the meeting of the PHRC to finalize and adopt the discussion that has been put forward. So this is still under discussion. This is not the final, but on the 21st of October, all the ideas will be put together and say this is now the flow chart that we want that we are recommending as the research process within Gauteng. So everybody is still welcome to send those inputs. And so this, like I indicated, that it was presented at the EMC, and now it was discussed with the extended EMC, which includes the hospital CEOs. And because it's a challenge usually to get them in a meeting, we've set up a forum that all the hospital and district research chairpersons sit. And we hope in our next meeting also, which is next week for this forum, we will adopt the new process. We will send forth, agree on the process and send it for adoption by the PHRC for the next meeting, and the SOP should be finalized. So that is where I'm going to end my presentation regarding the process for research.
Well, thank you very much, Bridget. Dr. Ikalafeng. We are basically having a few minutes. Can I suggest, Tess, that we go through your presentation and then we take questions and answers. There are 2 questions already. I think some questions are on the chat as well. So if I can suggest, please take your questions and put in the Q&A. If you have it there, just copy and paste it. We'll go through the next presentation by Ms. Padayachee from the Health Systems Trust. I really appreciate the support that she's provided to the Jhb DRC in terms of resolving issues. And Dr. Ikalafeng has also been very supportive to us. So we appreciate all the support that they're giving and participating. And just for the participants' information, we have 142 participants. And so there's a good participation in this. So thank you all very much for joining us. Tess, if you can unmute and also start your video and proceed. Thank you very much.
Hi, Prof. Thank you so much. I really appreciate the invitation to Health Systems Trust to be part of this very exciting initiative. So I'm glad that Bridget's presentation has a lot of congruence with mine. So I think we're all kind of on the same page, but I'm going to keep my presentation quite brief, just in terms of, sorry, I just want to move to the next slide. Yes. So just an overview of my presentation. I'm just going to outline a few things about Health Systems Trust for those who might not know about us. I want to provide a little bit of context and backdrop around the development of the National Health Research Database. I want to also clarify HST's mandate in terms of the implementation of the database and what our scope of practice is around the implementation. And then I'm going to keep the how to use NHRD quite brief, but I want to link the audience to specific resources that are available to make the application a lot more efficient. I think I'd like to take this opportunity to also just highlight some of the systemic challenges that we face. And I think Bridget has beautifully outlined that this is not a very clear picture. It's quite a messy picture in terms of our health systems, health research system at this point in time. And I want to end with some future opportunities, specifically in relation to the National Health Research Database. So I think it's important for you to understand that there's a lot going on with the development of the National Health Research Database. I'd like to introduce the team from Health Systems Trust. We have Dr. Anibale Kois. I think he's joined our webinar today. He's our biostatistician, and he's really leading the process of automation and trying to move us into the fourth industrial revolution in terms of our NHRD work. Mr. Rian van Eerden isn't joining us today, but he is our lead software developer, and he's been with us through this journey for quite a while. And finally, Ms. Carmen Saisim is our NHRD master trainer and our provincial liaison, and she really is, she's built an excellent relationship with all of the PHRC administrators across South Africa. So that's just our team. About our organization, the Health Systems Trust was established at the dawn of democracy, and we have been working to drive change within the health sector towards more comprehensive and equitable health systems. And we mainly do this through our research and capacity development agendas. Health Systems Trust really provides management and implementation support across health districts in South Africa, and we have quite a strong foothold in the KZN province through our SA Shore project. We support the implementation of priority health programs. At this point in time, the dominant program is HIV and TB. We conduct essential national health research. Some of you might be familiar with the District Health Barometer and the South African Health Review. And through our projects and our activities in the districts and across the health sector, we provide and we generate information for planning, monitoring and evaluation and decision making. And finally, we offer guidance and mentoring and training on good practice developments. And I think this is quite an exciting area for Health Systems Trust because of the richness of our experience on the ground. So that's just a little bit about Health Systems Trust. I think I'm not going to spend too much on this slide because I think Bridget has really outlined the policy mandate around the development of the NHRD. Just to mention and reiterate that the custodian of the National Health Research Database is the National Department of Health, and Health Systems Trust implements, maintains, and leads the further development of features on the NHRD. But essentially, just to put things in perspective, the NHRD was really initially proposed to support the PHRCs in terms of their coordination function and their management of the health research agenda within their province. But having said that, I think as the NHRD has evolved over time, we find that there is a lot of congruence between the NHRD and the mandates of the National Health Research Committee, as well as the National Health Research Ethics Committee. And I think these points are very important because it shows that the NHRD speaks to the agendas of multiple important structures within the health research system in South Africa. Just to reiterate, I think Bridget's also covered this, but we are here and the NHRD is there to provide support to the provincial health research committees. Our aim really is to provide a central repository, and that I think it's an important point that as a country, prior to the NHRD, we really didn't have a central repository where our health research outputs could be accessed. And so I think it's an important ultimate aim to bear in mind as we move forward with the implementation of the database. And finally, very importantly, it's to generate strategic information to track research trends and, as Bridget has outlined, evaluate its alignment to the National Department of Health's research priorities as defined by the NHRC. So in a nutshell, there really are operational and strategic level value for the NHRD, and we work with a broad range of stakeholders, including the NDOH, the NHRC, the PHRCs, and now the district research committees as well. And all of this, I would imagine, is moving us swiftly towards a system where local evidence can be used to support decision-making within the health research system. And that's why I'm so excited about this webinar series, Prof, because I think that's really catapulting us in that direction. I thought it would be important just to also give people a sense of where we've come from. So the development of the NHRD really started with a rapid assessment that the late Professor Bongani Mayosi had requested the Health Systems Trust to undertake. And I think this was an important starting point for the database. What we found with this rapid assessment is that across the 9 provinces in South Africa, there were really different approval processes. There was variability in terms of the terms of references that were being used by the provinces. And generally, there was just no uniform system in terms of approval for researchers who were wanting to conduct research in public health facilities. And then we moved on. We used that information to develop the prototype in 2012. And we were well supported by 2 provinces, KZN and the Western Cape. So they were quite advanced in terms of their management and coordination functions and structures. And we modeled the NHRD against their SOPs. And I think that's important also to bear in mind as the database develops. So our piloting and refinement of the database took place between 2012 and 2014. And we were given the go-ahead from the NDOH and the NHRC to go live. 2015 was quite an active year for the project. We had set up our help desk. We piloted and went live in KZN in the Western Cape in September 2014. And by January 2015, all 9 provinces in South Africa were using the NHRD. 2016-17 onwards was really around the stabilization and penetration of the NHRD across the provinces. We undertook an internal evaluation as well as an external evaluation on the NHRD in that year, and we responded to some of the capacity strengthening or the capacity building requests from the provinces. And it was also the year that we launched the national platform, and I'll speak to that a little bit later. So at this point in time, we're at a very exciting phase of development for the NHRD. We're really looking at automation. We're looking at expansion of the NHRD towards additional structures, including the district research committees, central hospitals, academic health complexes, and I'll give more information about that. So I just thought it would be important to tell the story because it's evolved over time and it hasn't been a static process. So just to clarify HST's mandate, we are funded by the National Department of Health, and we work towards fulfilling our mandate that is very clearly outlined in terms of our annual work plans with the department. Just to outline, for the financial year 2018-19, we were mandated to maintain and host the NHRD, to implement an automated classification system, and develop and pilot a solution for academic health complexes. And I think Bridget and academics in Johannesburg would understand the imperative around trying to reduce the turnaround times by including academic health complexes into the approval process. So for the researcher, I've summarized some of the tips from our side in terms of ensuring that your application is submitted successfully. I think at this point in time, it's one of my top tips is to understand the standard operating procedure in the province. And as Bridget has outlined, it really is an evolving process. And so to watch that space and really understand what the SOP is requiring of the researcher. We would also propose that researchers use the help desk support and other provincial resources that are outlined on the website. So we have a resources for researchers tab where you can access all of the contact details for provincial health research administrators and chairpersons across the country. So if you're ever stuck, that's one place to start. I'm going to emphasize point 3 a little later on, and that is, it's really important that researchers apply using the correct portal. And I'll explain a little bit more about that later. And finally, the purpose of the NHRD is to create an all-encompassing repository and communication system between the PHRCs and the researchers. So there are features that researchers might not have explored, but you can communicate directly with the PHRCs using comment boxes, and that just helps things along in terms of coherence of communication between the two parties. So on a very basic level, this is the URL, and that's the landing page that you will find yourself on. We have a user manual for researchers. I would recommend that if you, it's fairly self-explanatory, but if you do run into trouble, I would suggest that you consult the manual. We also have a variety of different support mechanisms for researchers. So we have a frequently asked questions page. You might want to consult that if you are running into trouble. As I've mentioned, we also have a full list of contact details for all PHRCs across the country. And if you still have trouble, we at Health Systems Trust host the help desk for the NHRD, and we would be very happy to assist you with anything that you may need. So this is the help desk email address, and we usually respond quite quickly and direct you to the relevant resource. So this is the issue I had alluded to earlier. So in 2015, as I've mentioned, we responded to the need for us to develop a national portal for researchers requiring access to national data sets or access to officials at the National Department of Health. And so we launched the national portal, but then quickly realized that not all researchers understood the difference between accessing provinces and accessing the National Department of Health and when to do so. So when you land on this first page to begin your application, it's important that you clearly understand what it is that you're trying to get access to. So if you are requiring access to conduct research in public health facilities, either in one province or across multiple provinces, you will need to apply through the portal on the left, where you've got all the logos of the different provinces. But if you are requiring access to a specific national data set or officials at the National Department of Health, we would request that you go through the national portal. Now, there are debates going on in terms of whether this is causing too much confusion. We've had a number of researchers who have applied incorrectly and they haven't received responses, clearly because it's gone down through the wrong portal. So this is something that we will have to discuss with the department and other stakeholders, but essentially at this point in time, I think it's important. And if you're unclear, send us an email and we'll help you work through exactly which portal you need to apply through. For PHRC administrators, I just want to highlight some of the new features that are included in the NHRD. So we have responded to some of the challenges that PHRC administrators had experienced previously in terms of accessing raw data. And what had happened is that provinces who wanted to implement more advanced analyses using the raw data were a bit confused in terms of what the different fields meant. And so we've responded to that, and we've improved the access, and we've created a guide that will assist administrators in terms of analysis of their raw data. We've also included new study fields, and I'll speak to that a little bit later. We have improved our automated reports, and this is still a process that's, I think, the automated reports is a bone of contention, because different provinces have different requirements, and so it's always difficult to satisfy all provinces. But I think we've developed a suite of automated reports that at the very basic level provides information, both operational and at a strategic level as well. And I think excitingly for Gauteng, specifically because of the challenges that the province has been facing, we have two solutions for academic health complexes and central hospitals that is currently under discussion, that hold promise in terms of improving the turnaround time for approval. So not to belabor the point, but basically we have improved our automated reports, both for the National Department of Health and the Provincial Health Research Committees. We have updated our database fields, both in terms of our operational and strategic reports. As I've mentioned, we've restructured our raw data so that it's a little bit more intuitive and better documented in the guide. And this will allow researchers who are interested in this particular field to also understand what the fields mean and be able to analyze the data correctly. And we have introduced new categories in terms of research activities and health categories. And I will speak a little bit about this now. This is the guide that I spoke to. And these are the new fields. So if you've been somebody who's submitted an application through the NHRD maybe a year or two ago, you will notice that this is a significant difference between the health categories that were used previously, that were modeled off the KZN and the Western Cape Department of Health standard operating procedures. I think that this provides us with a much better system for being able to track research trends. It's also internationally recognized and supported by the National Department of Health and the NHRC. We've also updated our research activities categories, and this is now work that's being taken forward in terms of our intentions to automate a lot of our classifications of applications in the system. As I've mentioned, these are automatic reports that are available, and we've introduced 3 new automatic reports. The research expenditure per health category, and this is also quite an interesting one, because this is it's always difficult to get researchers to disclose their funding sources, and so it's a report, but I'm not quite sure how accurate the outputs are at this point in time. And then we've got health category per province, and we've got unique applications received. So I want to spend a little bit of time talking about some of the solutions we have proposed to the National Department of Health around the implementation of a solution for academic health complexes. And the backdrop to this is that there was a significant delay in terms of approvals, and we wanted to explore the possibility of embedding the NHRD within academic health complexes, but still keeping it within the NHRD database. And Between September last year to March this year, we piloted the solution in 2 hospitals in Gauteng, Ikalafeng Hospital and Steve Biko Academic Hospital. We now have 2 solutions. One that aligns well with the NHRD process flow. So it basically would mean providing a PIN to a facility that has a similar process flow. And when I say process flow, I mean specifically around how their system is set up in terms of providing approval. So for instance, in Ikalafeng Hospital, they provide a provisional approval to researchers pending ethics approval, whereas Steve Biko Academic Hospital falls in line with the way the NHRD has been set up, in that an ethics approval letter is required before access approval can be granted. So we've developed 2 solutions, and the discussion is now around how and when this rollout will happen in Gauteng. And so we eagerly anticipate that we'll be able to start with rolling out this solution to the central hospitals and other academic health complexes in the country. So some systemic challenges, and just to be very clear that the system is not perfect. And I think when you implement a system or a database within an imperfect system, I think you're bound to have challenges. So some of the persistent issues that we face that go right back to 2012 when we did the rapid review is that we still have variability across provinces. And it really is difficult to have a standard kind of system for the country when different provinces undertake different standard operating procedures. And so I think that's a persistent challenge. We also recently had to migrate our NHRD database as we changed service providers in the last month. So that has caused a few temporary issues in terms of strange duplications, but we've managed to sort most of them out. So for administrators who are on the webinar today, I think you would have seen a few interesting, strange things going on in August, and we thank you for your patience. We also noted through the pilot that providing PINs to academic health complexes and central hospitals might not be as simple as just providing a PIN. There is a process of consultation, and all academic health complexes and central hospitals don't follow the same process. So we have a central theme here that there isn't a standard way of coordinating research in the country. And finally, we have a persistent problem of high numbers of pending applications from previous years, some of them going back to 2014, 2015, and we are trying desperately to find out exactly why this is so. And so we will work with the provinces to try and figure out exactly how we can clear this. The reason why this is significant is because when you start doing your turnaround calculations as a province, these pending applications skew the results in a negative way. And so it's always good to try and clear those if approval has been granted using some other system, which we wouldn't promote. But I think it's an important point, especially when one starts to track the performance of PHRCs in terms of their turnaround times. And finally, I think there is a lot of potential in terms of opportunities for future development of the NHRD. So we started off as, you know, an administrative tool with a very clear kind of goal to support the PHRCs. We've now, I think we've got about 9.5, close to 10,000 registered studies on the system. And so we can move towards the more strategic purpose of the NHRD. And I think, Prof, you would probably appreciate this, that there is huge potential for us to be able to harness local evidence to support evidence-informed decision-making and the use of research outcomes for decision-making. And yeah, so I'll leave it there, food for thought.
Well, thank you very much, both Tess and Bridget. I think we have about 8 minutes left and there are a flurry of questions. Perhaps we can just quickly go through these questions, some easy ones. I think Pins were referring to access to the NHRD, which Tess was referring to for administrators, not for the average public that you usually register on the system. So I'll just cut the sort of, we'll deal with that. There are a number of questions that were asked, and let me start with Tess. I think Mohammed Rasool asked about timelines to get through the backlog at PHRC and how you expect the new system, when you expect the new system to be in place. Perhaps timelines for the backlog, how soon are we expecting that to be dealt with for the province? Bridget? Sorry, Bridget, I'm going to have to put you on. There you are. You can use the WhatsApp to talk to me.
Okay. I think I did try, I typed the answer.
Okay, Bridget, if you don't mind just switching off the other phone perhaps you have for the audio if you mute it. Ah, good.
I think I'm back. Okay, I'm going to switch.
Okay, if you unmute yourself. All right.
Okay, can you hear me now?
Yes, I can hear you now. So that's great.
You can hear me now?
Fine.
Okay. All right.
Yes, so
yes,
let me switch off.
Okay, yes.
Go ahead.
Regarding the timeline to clear the backlog, Prof, we have established a forum, a reporting forum where we can all sit, like I said, the backlog does not necessarily rely with the provincial office, but lies, it's jointly together with the hospital research chairpersons and the district research chairpersons. So if we're all in one room, so we've got this forum that is established and meeting monthly and sort of a reporting platform to ensure that we are all on the same page and every protocol gets monitored. So thus far we managed to do very well for the previous financial year. And in the next meeting, we hope that for this new financial year, we will be clearing. So for me, that forum is sort of a key to ensure that we all report on a monthly basis all the studies that are being provided from central office.
No, that's fine. If I can just quickly add here, I forgot to do this early in our conversation. This is just to show you what's happening in Joburg, and as the Jhb DRC, I think people are anxious about what we're doing. So just to say that in the Joburg DRC, we have processed 84%, it's actually 84 of the 100 proposals, applications that have come before us from January. So as you can see on the spreadsheet, we've dealt with almost all of it except for 16 studies that are with the reviewer and with the BUSI, and in fact that I think should come down in the next few days. So just to give you feedback on the numbers, and I think this might be useful for the province to also do, Bridget, is to share information publicly that gives people a sense of where the backlog sits and what timelines are. And for the audience, I think we will try to provide a sort of turnaround time measure and measure ourselves against that on each occasion. So let me just quickly go to one that involves Tess as well. So Tess, there was a question about, do people have to apply via the province? Maria Fortunas asked, do you have to apply via province if you via the province that you work in, even for national research, or if you are doing, in other words, if the research is more than one province, a national piece of research, 9 provinces, does it mean we've got to apply to each province? Or can the province national take that on? Or is the national dealing with just the National Department of Health that building in Pretoria?
Yes, Prof. So if you have a multi-province study, you would have to use the portal on the left. What we've done is that with a single application, you can identify all the provinces that you wish to submit the application to. So in the past, you would have to do it 9 times separately. And so we've kind of created an efficiency in the system. So you would need to go through the portal on the left and not the national portal, because as you correctly said, the national portal is really for the structure at the National Department of Health and access to officials and national data sets.
Okay, no, thank you for that. Tendani asks a question that I think you might be able to answer, Bridget. She says, I see that the universities are not involved. Do you want to share how the PHRC works with the universities, just to give you a sense of that issue? Bridget, can you hear us?
Tendani's
Yeah.
question is not that much clear, because the second says hospitals
Well,
refers
perhaps
studies
just, you know, talk about the relationship between the universities. I think the gatekeeping of other universities is a question. I don't think that there is any gatekeeping happening in the decision-making process. Different research committees will submit an application with their you know, their applications, as long as it is accredited with the National Health Research Ethics Committee, they are viewed the same. We do have in Joburg challenges with the fact that there are differences in the way ethics committees are functioning, and we internally have that challenge. But maybe you could talk about, Bridget, what your relationship is, how have you worked with the universities, and is there some favoritism happening? I think that's the concern that's being raised.
Regarding the universities, most universities have got their HRECs, and once the researcher has got an approval from an accredited HREC, then that approval is being considered in the department. There has been a bit of a discrepancy. I wouldn't call it discrepancy, but something that needs to be cleared between some of the universities, that university HRECs, one not accepting the other one's HREC. And I think that one has been put forward to say that there should be reciprocity, you know, of HRECs. However, it's only one university that I know of, and I think that has been escalated. But unfortunately, some of the universities don't have, especially our, they don't have HRECs and have to rely on the bigger universities for that. But universities are not gatekeepers. Once it's accredited, the relationship with the department is that it is accepted.
Okay, a question to, thank you, Bridget. A question to Tess. Is there an example of raw data that might be available, raw data access? And I think that was a question asked. Would people be able to get raw data? Now, this is actually NHRD raw data. It's not researchers' raw data. So perhaps you can clarify that and what it is and how people might access the raw data available on NHRD.
So the raw data is not available to the public unless you get the approval either through the PHRC for their provincial raw data or the National Department of Health for the national aggregated data set. So unfortunately, it isn't available directly to public and other researchers who might want to access the data for analyses of their own. But it certainly is, I would assume, and Bridget can clarify that if a request is made through the NHRD to the province for access to that database or data set, that would be possible.
Yes, and I think that's, I'm not sure what, you know, Natasha Kamisa asks about secondary research using existing data. I think that's the same question. Data that's available will need a permission to be asked for. So I think that covers that question. I think there's a question which you perhaps have already answered. I just want to go through to make sure. There's a person, Evelyn Majapelo, asked, I have clinical research studies submitted 6 weeks ago. Timeline has passed, but still to date, no provincial approval. Can I start without the provincial approval? Go for it.
Yes, Prof, we have given the researchers a go ahead to say that, because mostly you find that a trial is not done in one site. You know, then it involves quite a number of sites. And then the Joburg Metro has already had their meeting and they've provided the permission. And then maybe Ekurhuleni have not had their meeting yet. The permission is not yet provided, and so forth. So in such instances, we allow the researcher to say, once you have the site approval, you can go ahead and collect the data so long. And then when we get the other approvals, then we will write one provincial approval. So we have been quite lenient, understanding in such issues, because the challenge is that the district research committees sit at different times of the month. And that is what happens, that sometimes a protocol takes 3 months, because if you sit once a month and your protocol gets submitted just a week before or a week after the meeting has already been held, then it's going to be reviewed in the second month. And that second month, it's already 12 weeks. That's the challenge. So we say that committee that has already had their meeting that month, they've given you permission, go ahead. And whilst we are waiting for the other committee, because unfortunately your protocol will be reviewed in the next meeting, then you can continue. But we are trying very hard to see how can we streamline the meetings of the DRCs so that for as long as they all sit at different times, we'll never have a 6 weeks turnaround time for one study.
Yeah, and I just want to say that, as a Joburg DRC, I think the questions are all valid. I'm a researcher, as are the people on the committee. We're very keen to make shorter turnaround times. And, we're trying in Joburg. I think the SOP that Dr. Ikalafeng mentioned is something that we would like to make sure kind of makes the process simpler and easier. So even though you might feel a little bit hard done by, it's clearly a work in progress. So I'm going to leave it at this. Unfortunately, we've taken 5 minutes too much time of other presenters. So thank you once again to Dr. Bridget Ikalafeng and Dr. Tess Padayachee. Jhb, you haven't had any comments, but perhaps you'd like to share some thoughts in closing. I'll give you a minute to say something if you don't mind just sharing your thoughts. Jhb, Doctor, is it Mr. Motivi or Doctor? I'm not sure. But if you're free to comment as from the Department of Health nationally.
Okay, I just want to comment. There was a question which relates to NHRC. I just want to say NHRC doesn't provide a grant permission to facilities. Facilities are approved by the province of that particular hospital. So the NHRC is sort of providing governance for the whole research system. Then the other issue which I wanted to highlight, especially to researchers, is to be aware of different requirements when you have to do research in South Africa. First of all, for any research, you need to have a scientific review, which need to be approved. Secondly, if it is using human subject, it needs to have HREC, Research Ethics Committee. If it is a clinical trial, it needs to go through SAPRA, and then after that, it needs to be registered with the clinical trial register. And then if you want to get permission in the province, that is where you use the NHRD to apply for permission to be allowed to do those studies. So I think it's important for every researcher to be aware of all those processes. And if you are aware, it may be easier even to streamline, some of the application, you can do them simultaneously. So I just wanted to say that. Thank you.
No, thank you very much. Just a quick, the question that Bridget has been asked is, you know, you get a challenge, and I think this might be some of the other questions about multi-province decision making in a district, in a Gauteng. If a person wants to do research in all 5 districts, and that's, for example, interviews with senior managers on some simple issues, it will take 5 different committees to actually review it to get permission. Is there not a way we could agree to more than one facility research to be reviewed at a provincial level and to involve the research chairs in a process like that? Is that a possibility, Bridget? And I think we'll call that last and then we'll close. So thank you all very much. Do you think that we could explore that? Because I think that's one of the problems. I mean, Mohammed Rasool asks the question, why do we need so many research committees to review it? And I think the problem is that if there's work being done in 5 different districts, they all need to somehow know that there's a permission, because the context might differ and there might be an issue. And it's under those circumstances. So at the moment, the Gauteng Health circulates the protocols applications to 5 different districts. They then have various processes, some of them poorly administered, and then it comes back to you, and then you make, you know, at the moment, how do you make the decision? Do you then decide yes, or at the moment it seems different districts will decide, give permission, and people proceed? Can't we rationalize that process, especially for you know, for research, it's multi-site?
I think that we need to it's a possibility, and actually something that, you know, we really need to do. And I guess, you know, in this committee that we've just a joint forum, that is where we can decide to say that, you know, the study is applying to all of us, and we are just approving it, or one committee doing it and sending the comments to everybody.
Yeah.
So that is one thing that we can also put on the SOP.
Yeah. So I think that's something we can, sounds like a good idea. Just last, I think, you know, is there fundings, resources in the Department of Health or HST? Is it available to researchers? I think, yes or no? Or maybe.
A big no.
A very big no. But when they find the answer of who does have funding, please let me know too.
Okay, so when you get the money, come call us. No, that's fine. That's a reasonable response. I think people must understand that this is the health service itself. You know, there is obviously money that could be put aside for research for the Department of Health, and that's another conversation. So let's leave more time. I think, thank you very much, Bridget and Tess and Tshilidzi. I really appreciate your spending time. I think the people that have been part of this discussion may not be entirely satisfied unless they see action on the ground. So I think that as officials in the Department of Health, we get the message clearly. We know that this is a challenge, and we will try our best to try and address this problem. So thank you. And I think you know, Bridget, Tess, and Tshilidzi, welcome to remain. If you need to leave, just leave. But we have 3 other presenters, and I want to move on to them. I know that time is going to make it slightly challenging, so we'll hope they will adjust. We'll try to finish at 4 o'clock, and we're 10 minutes into our time. So let me just share briefly the people that are going to be presenting to us today are actually you know, researchers who've done work within the Department of Health, specifically Johannesburg. Well, not always, but have done work, and we've tried to identify people who've done work in Johannesburg. So I'll wait for them to share. There's Dr. Denise Evans of the Health Economics and Epidemiology Research Office at the Wits Health Consortium, and she will share something with us, the title of which is The Treatment Outcomes Amongst Children, Adolescents, and Adults in Treatment for Drug-Sensitive TB in 2 metros in Gauteng Province. I'll just announce quickly the other presenters are Dr. Elise Semington and Dr. Charmaine Blanchard. and I'll introduce them as we proceed. So with that, thank you very much. Denise, you're ready to go. If you'd like, just feel free to share and proceed.
Thank you, Prof. Can you hear me and can you see my slides?
Yes, great. Thank you. All good.
So thank you so much, Prof. And really, on behalf of all my cohort authors, thank you so much for the opportunity to present these results from some of our work. So as you already mentioned, the title of the presentation is Treatment Outcomes Among Children, Adolescents and Adults on Treatment for TB in 2 metropolitan municipalities in Gauteng Province. So knowledge gaps remain regarding how TB treatment outcomes differ by age, especially in countries with a high TB and HIV co-infection such as South Africa. Prior studies on TB outcomes have focused on children, on adolescents, or on adults individually, without attention on how outcomes differ across the full age spectrum within the same setting. So a thorough comparative analysis of treatment outcomes may help identify specific age categories that are most vulnerable and should therefore be targeted for interventions or future studies to better understand predictors of poor outcomes or interventions to improve treatment outcomes. So what do we already know? So we know for children under 5, they are at increased risk of TB infection. We also know that this group is difficult to diagnose and treat TB. We also know that TB disease in children is a marker for recent transmission. For the adolescent group, we have the 10 to 14-year-olds, that's the young adolescents, the 15 to 19-year-old, the older adolescents, and the 20 to 24-year-olds, which is the young adults. We know that this group is a vulnerable population with unique needs. They have poor adherence to treatment compared to adults and high rates of default and treatment failure. However, reports are conflicting. In some reports, adolescents, and they've used 10 to 19 years of age, have better treatment outcomes, less death and less severe disease. Then when we look at the older group, so 50 years and older, for this group, we know that they have a lower treatment success rates, they are also more difficult to treat, they have more complex disease and often more severe adverse events. So if we look at the setting for the study, so we know that South Africa has a high incidence of TB. Estimates from 2018 estimate the rates at 520 per 100,000 population. For Gauteng Province, we know that it has the most populous of the 9 provinces in South Africa. It also has the second, during the study period, it had the second lowest TB incident rate, but has the greatest proportion of TB and HIV co-infection, with 68% of TB patients estimated to have HIV. So if you've seen the 2 figures below, this was taken from the 2018-2019 District Health Barometer. You can see the figure in the bottom left. This shows Gauteng, sorry, it's a little small, but the third bar from the left is Gauteng. And Gauteng diagnosed 16% of the total number of TB clients that were diagnosed with drug-susceptible TB during 2018 and 19. And then 91% of those patients started treatment. And the figure on the right shows the treatment success rates. And you can see third from bottom, Gauteng Province at 74.5%, which is below the national average for South Africa at 76.3%. So for this study, we not only focused on Gauteng, but we had data for 2 metropolitan municipalities, the city of Johannesburg, as well as Ekurhuleni. And since we were just discussing approvals, I think I would like to mention that at the time of approval, we had requested approvals for all the districts in Gauteng Province, but had extensive delays. And then by the time we had to complete the analysis, we only had data for the city of Johannesburg and Ekurhuleni. So the research question that we posed was, how do TB outcomes differ across the full age spectrum within the same setting? So the aim of our study, the study aimed to describe the treatment outcomes among children, adolescents, young adults, adults and older adults that had initiated treatment for TB in 2 metropolitan municipalities in Gauteng Province. So this was a retrospective analysis. So we used data from the electronic TB register, and as I already mentioned, for the city of Johannesburg as well as for Ekurhuleni. We included patients that initiated treatment for drug-susceptible TB between January 2010 and December 2015. We confirmed a TB diagnosis as documented in the electronic TB register. We included patients that initiated a standard first-line TB regimen and excluded patients that were receiving INH prophylaxis. We removed any duplicates, and we also excluded patients that had a missing age, had a known drug resistance, and were also transferred into TB care from outside of the city of Johannesburg or Ekurhuleni because we didn't have any information about their prior TB history. Our age categories, we had children under 10, our young adolescents from 10 to 14 years, older adolescents from 15 to 19 years, our young adults from 20 to 24 years, adults from 25 to 49, and then our older adults 50 and above. For our analysis, we reported treatment outcomes as they were reported in the electronic TB register. We only included patients that had a treatment outcome assigned. And the outcomes that we were interested in for the analysis was all-cause mortality or loss to follow-up, which was defined as treatment interruptions of 2 months or more. Patients were followed from treatment initiation until the earliest of death, loss to follow, or follow-up within 10 months after treatment initiation. We used Cox proportional hazard models as well as Kaplan-Meier survival curves. And then because we considered death as a competing risk for our outcome of loss to follow-up, we used fine and gray competing risk regression to control for death and estimated loss to follow-up. And then also we conducted a sensitivity analysis where we included all patients who had a treatment outcome assigned in ETR, regardless of when the outcome occurred. So you can see on the left-hand side, so we had over 200,000 records from the city of Johannesburg and Ekurhuleni for the period January 2010 to December 2015. We excluded 3,600 patients who received INH prophylaxis. We also excluded 1 patient that was missing information on age. We excluded over 20,000 patients who transferred in from facilities outside of the city of Johannesburg or Ekurhuleni. And we excluded 790 patients who had evidence of drug resistance. So just for our sample 1, which was drug-sensitive TB patients, we had over 182,000 patients. For the analysis, for the outcomes of death and mortality, where we only considered those with available outcomes, we excluded patients that were still on treatment at 10 months, and also those that transferred out or did not have an outcome assigned. And so for that analysis, we had over 170,000 patients. So when we look at patient characteristics, 65% had initiated TB in the city of Johannesburg, 45% were female, 94% were new TB cases, 84% had pulmonary TB, and 37% were smear positive, and an equal amount, 38%, had an unknown smear status. Just to note here that Expert was rolled out in 2013, and so the diagnosis method using expert increased from 0% in 2010 to 63% by the end of the study period. Still continuing on patient characteristics, when we look at the case definition, 69% had bacteriologically confirmed TB, 16% were clinically diagnosed, and then as expected for the children, this was much higher at just under 51%. And then you can see in the older groups, there was a predominance of bacteriologically confirmed TB. When we look at HIV status, 64.7% of the TB patients were co-infected with HIV, and you can see in the adults, this increased to 76%, and in the older adults at 55.4%. When we look at ART coverage, so 2/3 of the HIV positive cases were on ART, and 25.2% were not on ART, and 14.5% had an unknown ART status. So it's also interesting to note that the young adolescents, so the 10 to 14-year-old age group, had the highest rate of ART coverage at 64.3%. And then the young adults, the 20 to 24-year-olds, had the lowest rate of ART coverage at 54%. So when we look at the treatment outcomes, we had overall treatment success rate of 84%. If you look at the figure on the top left, all-cause mortality, that's the Kaplan-Meier curve, and you can see at the table at the bottom, also on the left hand is the adjusted hazard ratio for mortality. So compared to adults, which is the reference group, older adults were at increased risk for mortality, and all the other age groups, the children and the young adolescents, older adolescents and young adults had a decreased risk of mortality compared to the reference group of adults. If we look now on the right-hand side, loss to follow-up, the Kaplan-Meier curve on the top right, and the results from the Cox proportional hazards at the bottom. Again, adults as the reference group, you can see that young adults, the 20 to 24 age category, were at increased risk for loss to follow-up. The children and young adolescents, as well as older adults, had a decreased risk of loss to follow-up compared to adults. And the estimates were very similar when we did the competing risk regression, and we look at the sub-distribution hazard ratio in the last column of the table. So we also looked at other predictors of loss to follow-up and mortality. And you can see that patients, when we look at HIV status, the table on the top is for loss to follow-up, and the bottom is mortality. So patients with HIV on ART had a lower risk of loss to follow-up. So you can see in the top table, HIV negative patients is the reference group. So HIV positive patients on ART had a lower risk of loss to follow-up, and the other groups had an increased risk of loss to follow-up. And when we look at death, being HIV positive and on ART, also had an increased risk of death compared to patients without HIV. And then also just to note, so for other predictors for loss to follow-up, we also observed that males compared to females and patients that had a previous treatment versus new a TB episode were at increased risk of loss to follow-up. For mortality, we observed again previous treatment compared to a new TB episode, females compared to males, and also those that were clinically diagnosed versus a bacteriologic confirmation were at increased risk for mortality. So what were our study limitations? So issues related to accuracy and completeness of national data have been well described before. So in our study, we found data on age and sex was quite reliable. Data on HIV, ART status and treatment outcomes were not, and were missing in some instances. So we had to exclude a number of patients because they didn't have treatment outcomes assigned. And also for treatment supervision, although we did include this in the model, we were limited with our interpretation of what this actually meant, because we had a number of missing data for treatment supervision during the intensive and the continuation phase. Also important to note is that earlier versions of ETR did not have provision for experts, and results were entered as smear. And then also they did not have provision for ART start date. And so we only had ART start dates for 2014 and 2015, which really limited our ability to look at variables like duration on ART in our analysis. Our data was also de-identified, so we were not able to link to NHLS to get any other laboratory data. We could also not link to the Vital Statistics Register to confirm death status. And then in this study, we report all-cause mortality and not mortality due to TB. So in conclusion, these are just my conclusion slides. So young adults in urban areas of Gauteng experience a disproportionate burden of loss to follow-up and low coverage of ART among co-infected patients. So this group should be targeted for interventions aimed at improving clinical outcomes and retention in both TB and HIV care. And it's just interesting to note that our results were very similar to a study that was also published in 2019, but from Cape Town, a smaller cohort of over 23,000 patients between 2019 and 2013. They had much lower rates of HIV co-infection. So you can see there 18.5% for the 10 to 14 age category, whereas we had 49.2%. 12.9% for the 15 to 19 year category, we had 35.3%. And then 33.1% for the 20 to 24, and we had 48.9% for that category. But nevertheless, they still found that compared to the 10 to 14 year age category, so that was their reference group, those that were 15 to 19 and 20 to 24 years were at increased risk for loss to follow. And you can see in the little block on the left-hand side there, when we change our reference group, we also get similar for the 15 to 19, we get an increased risk of 1.93 and 20 to 24, 2.58. So this group is really a group that needs some attention. TB care needs to be tailored to the needs of these young people to improve patient retention. And then let's not forget the other group, the older adults. So as people with HIV experience longer life expectancy, healthcare systems need to prepare for the increase of TB in aging populations that are more difficult to treat and have worse outcomes. And in this group, there may be other causes of death apart from TB, but they do have more complex TB disease. There may be more delays in diagnosis, more severe adverse events, and also an increased risk of treatment failure, which may result in death. So we need to think of aggressive screening and aggressive management, especially of TB, comorbidities, and adverse events in this group. And with that, I would like to thank you for your attention and end my presentation. Thanks, Prof.
Thank you very much. So I really appreciate your presentation. I think the lesson that you present about us in terms of dealing with TB HIV is watch out for these young people. We really need to appreciate that the co-infection is actually quite high, and then the loss to follow-up is actually a real big problem. I think good clinical care, especially good communication with patients like that, are the take-home message. Thank you, Denise. Unfortunately, we won't have time enough for questions. I don't see any yet, but really appreciate you, sharing that information with us. Would you mind just sharing the presentation with me so that we could post it up if anybody needs to have a look at it, they could do that. Thank you very much, Denise. Let's go to the next presentation, which is from Dr. Elise Symington from the Department of Life and Consumer Sciences at UNISA. She'll speak on the maternal iron status and birth outcomes, the NUPED prospective study. I think she's assimilating a couple of studies, but thank you very much to Elise for sharing this, and please proceed. You can just unmute yourself. I think you're okay. Yes, ready to go. I can see a presentation and I can hear you quite fine. Thank you.
Great. Thanks, Prof. Thank you very much.
If we can just manage time, I want to finish by 4 sharply. So if you can try and manage your presentation by 1:45, and then we can close. If there are a few questions, we can take them at the end if there's a bit of time.
I'll do my best. Thanks, Prof. Yes, I'm Elise Symington from the Department of Life and Consumer Sciences at UNISA, and I'll be presenting results of my PhD study, which I did at Northwest University. And we appreciate, having the opportunity to share the work that we've done in this area. So just want to move on. In terms of background, so the question really is, why are we concerned about maternal iron status? So we know that iron deficiency during pregnancy increases the risk for premature birth, for low birth weight, and low cognitive and motor capacity of the child, which we obviously want to prevent or at least reduce. However, we should take note that there is a difference between anemia and iron deficiency anemia. For anemia diagnosis, we know that we only need an hemoglobin assessment, while with iron deficiency anemia, you also need, in addition to HB, you need ferritin or another iron status marker assessment. So it's an additional assessment that's required to determine iron status. So in South Africa, we have very limited information about nutritional status of South African pregnant women. So pregnancy data is limited. So the information we have are on women of reproductive age, and we know about 33% of women are anemic, and about 11% are has iron deficiency anemia. And the WHO estimates that from people who are assessed in terms of anemia, 50% of this is due to iron deficiency. But as we know, anemia based on a low hemoglobin level can be due to many factors, not only iron deficiency, but it could be vitamin B12 deficiency, folate deficiency. Infection can increase anemia prevalence. So there are a number of factors to consider when someone is anemic. So how is South Africa addressing iron deficiency? First of all, we've got food fortification of maize meal and wheat flour with 8 micronutrients, including iron. And then there is routine antenatal supplementation, which includes the iron supplementation, providing 60 milligrams of elemental iron. And this is provided irrespective of the iron status of the woman. So all the pregnant women receive this, as well as 5 milligrams folic acid and 1,000 milligrams calcium. The question really is, do we know how effective the supplementation program in South Africa is? And since we have so much limited data on pregnant women in South Africa and their nutritional status and their iron status, this really is a question. For an example, only 109 pregnant women were included in the South Africa Demographic and Health Survey of 2016. And there's no other national data. So local studies are used to determine what the status, and it's more smaller groups. But we know there is a high prevalence of anemia irrespective of the supplementation program. And since hemoglobin is routinely assessed, we still can't describe the iron status of women because hemoglobin is not a sensitive marker of iron. We need to assess iron markers as well to determine iron status. And therefore, our aim for our study was to assess the iron status early, mid, and late pregnancy, and to also determine whether the iron status has any association with birth outcomes, including birth weight and gestational age. So the results I will be presenting is published in a journal PLOS One in 2019. The link to the article is there. So if you're interested to read more details, because I will be leaving out some details in the matter of time, it should be available to you. And also for the larger study, we've published the study protocol in 2018 in the BMC Pregnancy and Childbirth. And this is for the larger study where we indicate the follow-up of the children as well until 12 months of age. Just shortly, the methods, it was a prospective cohort study, so it was purely observational. And the population was generally healthy pregnant women, and we were interested in following them up from early pregnancy, and therefore they had to be less than 18 weeks gestation, attending antenatal care clinics, which we have identified 4 of them in the regions B and C in the city of Johannesburg. We screened 1,340 women during March 2016 and November 2017, ultimately to include 250 women, because so many women present late at the clinics. It's a struggle to find women less than 18 weeks pregnant. We had 4 time points of data collection, and it was the baseline, which is when they were early in pregnancy. The second one was at 22 weeks gestation, the third at 36 weeks gestation, and at the 4th measurement was at birth. We measured, or we assessed the social demographics, the anthropometric measurements, diet history, medical assessment and history, which included ultrasounds, birth and neonatal assessments, as well as blood sample collection and urine sample collections at each visit. We got the necessary ethical approval from the Northwest University and the University of Witwatersrand, as well as necessary permissions. And I can luckily say at the end of 2015, we had a smooth process in our application. And all participants gave written informed consent before we started with data collection. So the results, in terms of the maternal characteristics, the median age of the women were 27 years. They were 14, the median was 14 weeks gestation. So they were all early second trimester. And the majority of them were living with a partner or were married, although still 41% of them were single with no, obviously less support then. The majority, let me just go one back. The majority of the women were either overweight or obese. That counted for 61% of the sample. 26% were HIV positive, and 60% of the women had a CRP higher than 5 milligrams per liter, so increased inflammatory status. In terms of the results of the birth outcomes, the median birth weight was 3,050 grams, and 14% of the babies were low birth weight. 11% of the babies were prematurely born, and the majority were males and were born, the delivery mode was vaginal. Just to report on the results on the dietary iron intake we assessed, the median dietary iron intake from food alone, not considering the supplementation, was 19 milligrams per day, while the estimated average requirement for pregnancy is 22 milligrams. So it was a little bit lower than the recommendations. And that's obviously why we do want to supplement, because we know we struggle to reach dietary recommendations with diet alone. Just to mention, the upper limit for iron is 45 milligrams per day. However, supplementation is quite high for South Africa. The 60 milligram elemental iron is provided. In our case, it was 55 milligrams per day. And we did not find any significant difference between the reported dietary iron intake for whether the women were anemic or iron deficient or not. So it seemed in this case the dietary intake did not have an impact on anemic or deficiency status. When we look at the status with the pregnancy progression, and as we assessed it early pregnancy, mid-pregnancy, and late pregnancy, we noticed that iron status really deteriorated with pregnancy. And this is in a situation where women are supplemented with iron. This is clearly visible where in the, which line is this? The orange line, which include the STFR, the receptors, which are increased, showing the increased need for the iron. And it sharply increased towards the end of pregnancy, showing that really that the iron deficiency increased, the prevalence increased in this group. When we did the regression analysis to assess whether the iron status had any association with birth outcomes, with the pregnancy progression over time, I just reported that iron deficiency increased. And with this, we could see at mid-pregnancy, we found associations with gestational age. And as expected, which we know that iron deficiency increases the risk for preterm birth. And we also saw this in this group. But what was surprising was that in the same group, the deficient group had an increased birth weight. So the babies born to anemic mothers in mid-pregnancy weighed about 205 grams more than the non-anemic women. And the babies born to women who were iron deficient at mid-pregnancy weighed about 207 grams more. So this was quite surprising results. However, this inverse relationship was not only seen in our study, there was another African study and several other international studies which have found similar results where there was an inverse relationship between iron status and birth weight. And we can explain this in a combination of two reasons. The first being that iron supplementation really worked in iron deficient women and it supported fetal growth. The second is that we should take note that there is a U-shaped association between iron status and birth weight. So as a low iron status can increase the risk for low birth weight, so can a high iron status and increased iron intake also increase the risk for low birth weight. There are studies that have shown that iron supplementation in iron replete women may have a negative impact on fetal growth. So our recommendation, therefore, is that we obviously need data and a national review of the nutritional status of pregnant women. But we also know that iron deficiency and anemia should still be prevented. But how can we do so safely? And we therefore recommend to revisit the current antenatal supplementation regime. And this is very timely because just this year, the WHO updated their recommendations for nutritional interventions to include multiple micronutrient supplements during pregnancy. And they recommend that it should replace the iron folic acid supplementation and include 13 to 15 micronutrients. And instead of a 60 milligram iron containing 60 milligram iron, it should rather contain a lower dose of 30 milligrams. So in conclusion, we've noticed an increased iron deficiency with pregnancy progression despite supplementation, and there are reasons which we can motivate why we think this happened, but due to time, but you can actually have a look at the article. You would be able to see our motivation there for that. And then iron deficiency increased the risk for preterm birth, and which we expect, and this is another reason why we want to reduce iron deficiency in pregnant women. And what we also found was an inverse association between iron deficiency and birth weight, which was the surprising part, but then makes us somewhat concerned about supplementing women who are not iron deficient. Therefore, our recommendations are to revisit the antenatal supplementation program. I'd like to acknowledge several people who assisted me and that was part of the whole team, as well as UNISA and the NRF for their financial support. I have the list of references if anyone is interested, and thank you very much.
Thank you very much, Elise, and we'll share your presentation online, and I'm sure that you'll have your details so that people can contact you. So I think the key message is to look at iron supplementation and make sure that it is doing the right thing, especially in the last trimester. I think we need to also review as we're going along. It's such a pity we can't have more time. We'll have to look at a way in which we can engage better on this question. How your process of data collection went and how easy is it to access data in the Johannesburg Health District. I think Denise brought up the TB register, and I think we would want to know as we're going along in future presentations how your data collection worked and what are the challenges around it. But let's move on to the next presentation. I think time doesn't allow us that interesting discussion. The last presenter is Dr. Charmaine Blanchard of the Non-Communicable Diseases Research Division at Wits Health Consortium, and she's going to present a pilot study to identify patients at high risk of having lung cancer. Thank you, Denise, and over to you. I think you can share screen. I see your screen, and I just need to hear you, and then we're off to go.
Good afternoon. Thanks, Prof, and good afternoon to everybody. I'm going to do a very brief presentation on our pilot study to identify patients at high risk of having lung cancer. And I am presenting on behalf of my co-investigators, Dr. Nita Graham and Dr. Tom Boyles. Okay. So I'm not going to go into great detail into the introduction because for time, but basically we do know that lung cancer is a leading cause of cancer death worldwide. And the overall 5-year survival is very poor for patients with lung cancer, especially if they have metastases. And in South Africa, lung cancer is also the leading cause of cancer deaths. And the majority of our patients present late, mainly because the disease is pretty asymptomatic until it's reached advanced stages, and also because of a lack of awareness of the patients on what to expect and what to look for. And then obviously the usual health system delays in accessing the appropriate care. Some of the risk factors are, obviously we know about tobacco smoking, which is an established modifiable risk. And we have a smoking prevalence in Gauteng from between 4.8% to 37.6% amongst men. And the estimated proportion of households is between 42 to about 53% that are exposed to tobacco use. And then, of course, we have our usual occupational exposure to carcinogens here in Gauteng, our biomass fuel use, and then the industrial fume carcinogens. Other risk factors include history of previous cancers, family history of cancer, a lot of the chronic lung diseases. And then we have TB, which in itself is not a risk factor, but it's a confounder, because what happens is patients are often presenting with symptoms that look like TB, are tested, found to be negative, may be started on empiric TB treatment, not getting better. And so this whole process can unnecessarily delay diagnosis and timely treatment for patients who may actually be suffering from lung cancer. And of course, we also have our limited X-ray and CT diagnostic services. So we looked at some previous studies, and what was found is that obviously the randomized trials using just chest X-rays with or without sputum cytology didn't show much impact on mortality from lung cancer. There were 3 studies using what's called low-dose CT scanning that did show good responses or results. The National Lung Screening Trial, which is done in the USA, was the biggest trial that was done with about 53,000 patients with just over 24,000, 25,000 per arm. One arm, they did the low-dose CT scanning, and the other arm, they did just the usual radiography for screening. And what they found is that in the low-dose CT scanning arm, there were about 25% of patients screened positive. and whereas with radiography, they were only about 7%. However, there were quite high false positive results, and so these were patients who would have undergone further testing only to find that they did not have lung cancer. The incidence of lung cancer was higher amongst the CT scanning group than amongst the radiography group, and the number of people needed to screen was 320 to find one cancer. And so each one that was screened would then have to go through a whole lot of other tests, and we'd pick up one cancer per 320 that was initially screened. There's a study by Welsh which incorporated occupational risk factors. So the low-dose CT scanning used only age, from age 55 and upwards, and a smoking history, whereas Welsh decided to include the occupational risk factors, and they looked at construction workers. And this was part of a larger study where they found that if they included the occupational risk factors, it gave them higher detection rates than using smoking history alone. And then there was the Nelson study in Europe, which found that who was screened with low-dose CT scan had early stage cancer, whereas the others, those that were in the control arm, mainly had late stage cancer. And they also showed a reduction in mortality amongst men and women over 10 years, those that were screened with CT scanning. The challenge, though, is that none of these, while these studies have showed good outcomes, none of them have really been implemented as nationwide scanning processes, and I think largely because of the cost and the low yield. And certainly in a country like South Africa, where we have very few resources, just doing these blanket low-dose screening surveys or studies would obviously not be helpful, and we just don't have the resources to support it. So what we were trying to do is develop a prediction model that will identify patients at increased risk of lung cancer. And so this is really just a pilot study for us to understand what are the, how would we identify these patients, and then also just to describe the lung cancer detection within our referral networks. And we're working mainly through Helen Joseph Hospital and the referral clinics. So we want to develop an internally validator model with algorithms so that we can identify the patients who have increased risk of lung cancer and screen those patients. And then obviously we want to, through this process, raise the awareness amongst healthcare professionals of lung cancer screening, and then how to implement the algorithm and tools, and then to assess and describe the epidemiology. So we've just implemented the study. Our standard operational protocols have been developed from the initial screening right through to follow-up. Our sites are at Helen Joseph, Discoveries Clinic in Laratong. We've implemented at Helen Joseph and Discoveries. Because of COVID, there's been a bit of a delay, and we will be implementing in Laratong in the next couple of months. We're aiming to recruit 500 patients as a pilot study, and then use the results of the study to develop a bigger study. So the inclusion criteria, our patients, we're starting with a younger age than the other studies. Our patients must be 45 years or older, and they must have at least a 2-week history of cough, weight loss, fever, or night sweats. And they have a negative expert or unable to produce sputum. The symptoms do not improve following a trial of antibiotics. These patients are eligible for the study, or a patient over 45 years does have a positive TB test and are not improving after 2 months of treatment. Exclusion is obviously patients not willing or unable to consent, and patients are not residing in Gauteng who are maybe just visitors to the province. We require routine investigations, so a full history. We are including risk factors and other chronic lung disease comorbidities, a chest x-ray, sputum, full blood count, creatinine, and C-reactive protein. So these, once we have all of this information, and our research assistants have interviewed the patients, and we've collected the clinical information from the doctors at the clinics, this is then what happens is the patient gives consent, we collect the information, and the pulmonologists and the specialists at Helen Joseph will review the information, the x-rays and tests, and then decide which patients need the CT scanning and which don't. If the patient does not need CT scanning, They will then send a recommendation back to the primary team as to how to manage the patient. If they do need a CT scan, they will continue at Helen Joseph, receive the CT scan, and then based on that scan, will then there will be further diagnostic workup. If the patient has cancer, they're followed up as per the usual process for oncology. If not, depending on the severity of the illness, will be followed up at Helen Joseph's respiratory clinic or referred back to the clinic of origin. The statistical analysis, we will be capturing all our data on RateCap, and we'll be using multivariate regression analysis to look at the factors that are significantly associated with confirmed lung cancer diagnosis. And the X-rays will also be analyzed using CheckSnet, which is a machine learning algorithm, and trying to see if we can design sort of a process whereby we can start using artificial intelligence to strengthen our chest X-ray diagnostic accuracy. The usual ethical principles apply for our patients. I'm not going to go to that in detail. And then our expected outcomes is that we'll have a number of newly diagnosed lung cancer patients correlating with our high-risk screening algorithm predictions, and that the number of patients diagnosed, we'll also have a number of patients diagnosed with serious lung diseases other than lung cancer. And we're going to be looking at the stages of lung cancer that's diagnosed, hopefully to downstage the stage at diagnosis. We'll also be looking at the association of the protocol with raised awareness of lung cancer within the primary healthcare setting, and especially with a high TB burden. And then we'll also be looking at the association of the protocol with reduced delays in diagnosing our patients with high risk for lung cancer, and then also for expedited referral of high risk patients to tertiary treatment centers. Hopefully through the study, we'll be able to develop a definitive model for predicting the probability of lung cancer in our population, especially with our high load of TB infection. And also we'll be able to inform a larger study from these results, both from the regression analysis as well as from the automated chest X-ray analysis, and then implement this on an expanded high-risk lung cancer screening program, and then from that, hopefully be able to make recommendations to the Department of Health for widespread implementation. So essentially, we're looking at having a screening program that is effective and that we can, that is doable within the resource constraints of our Department of Health. Thank you. It was very, very quick, but I don't know if there's any time for questions.
No, thank you. It was very useful, and it's certainly useful enough to understand, short enough to understand. So thank you very much, Charmaine. Really appreciate it. We have just a minute. I don't see any questions directed, but I think it'd be very interesting to see the outcome of the study. So we hope as you proceed, you can provide us a report. Maybe we come along to talk a little bit more about it. Perhaps in the literal minute we have, very quickly, are there any challenges? I know that Denise, you mentioned that you had tried to do permission in more than one, one district, and you got sort of stuck because you could only get 2 permission by the time you had your timelines. Charmaine, are you having challenges with the permissions, access, and issues? And Elise as well, was there a challenge in actually getting into the clinics you required? Just in closing, have there been challenges that you would like to share? Anything that you feel would help the DRC to improve the way in which people access facilities? Any comments we welcome from you?
Thanks, Shabir. From our point of view, we didn't have so much of a challenge through the hospital itself, because I don't know how the process works for us. As soon as we got provisional clearance from the ethics committee, they give us a letter which we submit so that we can submit on the NHRD, and then we give that letter to the CEO, and the CEO does give us permission directly. Through the district, it was very difficult. It required a number of in-person visits to the offices at Hillbrow to find who was the person ultimately responsible, because after 2 months or so, we hadn't received any clearance through the website. And by chasing up that person personally, I was able to, within a couple of days, get a written signed letter of permission. So it was a bit challenging, but I'm hoping that it will improve with time.
No, thank you. I think we're trying desperately to make sure that it's easy and accessible to all of the people. I think getting Bridget on board is to, to try and address that. And we are working with Dr. Ikalafeng to smooth out all the little hiccups. I think that once we get, permission, and just to respond to lots of the questions, people have asked questions like, who do we contact? I have circulated the website, so it's on the website DRC. You just look for profmusa.com, the DRC, and then you'll find ways to actually apply for research. I think it sets out the NHRD, exactly what the requirements are. And then also, if you have any issues, there's contact details. I will supplement that with contact details not only of the district, but also of the other districts, other facilities. As we go along, we'll try and make it easy for you to reach out, including the provincial officials, so that it makes it easy for you to do. As we're going to the next, next few webinars, we want to focus on beyond the review process and the difficulties we have. Hopefully we can speak to Joburg and improve that. But what we want to talk about is other goals for the DRC. How do we apply the health outcomes? How do we make a difference to actual health care? And maybe the questions on the ground. How do we make it easy for you to access data? Do you know of different databases, different data possibilities within the district? So I think we want to make it something that really makes it much, much easier for researchers to try and find ways to study and then make a difference to the population of Johannesburg. In closing, I just want to say that our next webinar, we have Dr. Professor Shabir Mahdi of the new Dean of Wits Medical School, who's going to Wits Faculty of Health Sciences, who's going to spend an hour with us talking a little bit about collaborations between Wits and the DRC and exploring some issues. I think this could be the same of other universities as well. And also talking about some tips for the young researchers. So please join us next month. It'll be like this, the first Wednesday of every month. So with that, thank you all. Be safe, go well, and enjoy. And I hope this has been a very, very useful session for you. Thank you for your participation. Bye-bye. And thank you to all the participants and the three presenters, Denise, Charmaine, and Elise. Thank you for your time and sharing with us. Take care. Bye-bye.